Hey guys, how's it going? Reed here. How's it going, guys? Reed Matrix here. Let me give you a few minutes to allow a few people to come on into the channel. Yeah. Today we're going to go over neuroleptics, also known as antipsychotics. You know, antipsychotics is probably not a good term for these medications. And because there's a lot of psychosis is just one of the symptoms associated with a whole other things. Um, so what they call just antipsychotics. I don't know. It's maybe better to refer to these as dopaminergic agents, things like that. So I think in our industry, we're moving away from the labels like they're schizophrenic or something like that, or they bipolar, things like that, to the actual mechanisms. And the receptors in themselves have to have their own level of respect because these are magnificent molecular machines that basically manage the details of your life without you having to get involved. And I would say those are very interesting structures to sort of understand how they work and how they operate. So we're going to go through typical versus atypical antipsychotics. And if you're studying for step 1, step 2, or step 3, then I think you're going to really know this, particularly in step 3. Those first 2 clinical experiences, I think if you understood the differences between typical and atypicals, I think it's going to make things easier for you. And most importantly, what I'm going to do is focus on the targets. With AI in healthcare, I think it's going to revolutionize learning, because you can get the response you're looking for as opposed to a different response that someone gave you. So I think AI is going to really be able to simplify all this stuff. At the heart of it, I don't believe this stuff is complicated at all. I think it's the person explaining it in the context they're explaining it. So hopefully I'll be able to simplify some of this stuff first for you. But first, let me try to find the targets of the drug first. So let me go here. And I'm just going to just look like Google to try to keep things simple so you have opportunity to sort of. So first, let me show you the targets here. We're just going to briefly go through a few things. Okay, so let's say here, mesocortical. You guys remember this mesocortical pathway? Schizophrenia, when it's damaged early on during the pre-pubertal stages. When this is damaged, this network is damaged right here. It can result in symptoms we label as autism in these early developmental stages. But after they cross certain developmental milestones, damage to the same mesocortical pathway can produce positive symptoms of schizophrenia when the network is hyperactive, and negative symptoms of schizophrenia when the system network is hypoactive. And we can see the patient present in 2 different modalities when we see the patients in there. With hyperactive symptoms, it could produce a lot of agitation. Agitation combative aggression, sort of like glutaminergic. The excessive dopamine causes the excess release of glutamate, and the glutamate is the excitatory neurotransmitter. And so that's why the positive symptoms can present with a lot of disruptive behavior, agitation, a lot of energy injected into the situation. Same thing, different with negative symptoms. That's a lack of symptoms, sort of withdrawn, and a lack of engagement and things like that. The negative symptom component may result as a lack of producing all the substrates needed to sort of operate the machinery. And so the hypoactive state is considered more of a deficient-like state, whereas the hyperactive is more of an abundance of too much of the stuff. But this is the target in schizophrenia. This is the target for positive symptoms, negative symptoms. And so really you're looking at this network, you're going to say, you want to say, oh man, which category do I use? Typical, atypical. But here's the target. Let me look at the receptor profile on the mesocortical pathway. Okay, let's see what it comes up with. Look at this. Can you believe it here? Dopamine receptors, right? The mesocortical pathway uses dopamine receptors, D1 receptors, D2 receptors, right? Okay, these receptors are involved in mediating function like attention, executive functioning regulated from the prefrontal cortex. We got that. Okay, dopamine receptor 1-2 perception. Then also on here are glutamate receptors, right? We also have GABA receptors. Remember, look at this. Glutamate, there are only two neurotransmitters that's located basically in all tissues. It would be glutamate, which is excitatory, and GABA, which is inhibitory. Yin and yang, yin and yang. We want to keep that balance between the two. So on this medical cortical pathway, we have glutamate receptors that can really activate this system. So you want to be able to choose medications that should be able to target this glutamate. Here, GABA, GABA receptors on it. So in many cases, we have to use benzodiazepines along with the antipsychotic medication, whether it's typical or atypical, so that GABA receptor also on those metabolic pathways can sort of help reduce the agitation, combativeness, and aggressiveness. Then they have other receptors here. Okay, so look at these three things: dopamine, glutamate, and then GABA receptors. Okay, so next, if those are the receptors on the mesocortical pathways, then let me just look at, if we look at typical antipsychotics, what do they target? You look at, see what receptors they target. So we know what's causing this, where are the receptors on. Now we know the receptors on the network. Okay, well, what typical antipsychotic can I do that would match those receptors, right? Let me add another field here. And so I'm going to say typical, okay. Describe the receptor profile, F-I-L-E. Okay, y'all know I can't type. I can't type and look at the same time. I exposed that. Okay, I exposed that. Okay, let me see here. Okay. Look here. Look, typical antipsychotics act by blocking dopamine receptors. That's why we want it, right? Which is thought to be the main mechanism of their antipsychotic effect. Why? Because here it is on the pathway, right here. There they are right there. We're hitting those receptors there. They also have varying degree of affinity for other receptors, right? Okay. So here, more detail. Here, the D2 receptor blockade. So the typical antipsychotics are known for potent blockade of the D2 receptors, particularly in the mesolimbic. We'll talk about that a little bit later, pathway. But look here, there it is, the D2 receptor blockade. So that's how we, now here, look at this, a potent, see there, they are known to typical, the typical antipsychotics are known for potent blockade. That's it. That's it. The difference between the typical and atypical when you need it is potency. Why? When the patient, many times you have people who come in that decompensated state, which represent more of a hyperglutaminergic state, and so they're agitated, combative, aggressive. And you have to depersonalize these symptoms for the individual because the network is malfunctioning. And you can't assign responsibility to the individual. You have to be professional and look at the symptomatology and figure out the networking and try to intervene. So in a situation, emergency room, combative, aggressive, agitated, just suffering, would you choose a potent blockade or dopamine or just a regular one? I would say potent one. And the reason why it's called typical is because you're likely going to have side effects to it. And side effects are some of the things you may want. It may need to reduce the psychomotor agitation and combativeness and aggressiveness. It may calm them down. And you want those things. Okay, so here in the typical receptors, Also, look here. Okay, they do, but mainly here. While D2 is central, atypical antipsychotics also interact with other receptors. I'm not sure what percentage of other receptors this would be. So I would say around 10%, combine all those together, maybe 10%. I'm not a neural psychologist, neurologist, whatever that is. So I may be misquoting this, but I think the other receptors are minor population here. So mainly with the typical antipsychotics, it's going to hit that D2 blockade. Now, the other things like the cholinergic and the histaminergic, they may result in some sedation and things like that. And I think this histamine receptor here is significant in typical antipsychotics because it's through blocking the histamine receptors that can result in the sedation. So these typical antipsychotics can be very potent in blocking the dopamine and reducing just the hyperactivity of that mesocortical pathway. And it also hits those histamine receptors to sort of help create some degree of sedation sedation for the patient. Here, if we block these cholinergic receptors, it's going to have anticholinergic response, meaning dry mouth, blurry vision, and constipation, which are the usual side effect profile for patients with typical antipsychotics. So if I give you these shots, then you may have dry mouth, blurry vision, or some degree of constipation or muscle stiffness and tightening, and that's what you want to watch out for. So this is a profile for the typical antipsychotics. Now, let me look at the receptor profile for the atypical. Okay. Okay. I don't need a question mark. Let's see here. Atypical antipsychotics, also known as second generations, are more varied receptor, have a more varied receptor binding profile compared to typicals. That's what I wanted to point out there. Right? So the atypical antipsychotics are used to really manage that mesocortical pathways and things like that, but it's primarily targeting dopamine. You can get some sedation because it targets the histamine receptors, and you can get side effects like dry mouth, blurry vision, constipation, because it targets the it blocks the acetylcholine receptors. And so those are the typical profiles for typical antipsychotics. Now, atypical antipsychotics. So let's look at the range of receptors. Right. So look, dopamine receptors. Right. Look, a lower affinity and occupancy for D2 receptors compared to typical. When they said potent, which would be higher affinity and more potent. This loose binding or rapid dissociation here, this loose binding or rapid dissociation from D2 receptors is thought to contribute to their lower risk of EPS, right? Okay, so remember on the typical, it's very potent, just the D2 receptor and some minor things. I think sometimes the use of Haldol and the fear that Haldol can cause sedation is a little bit overrated, because the main target for those atypical antipsychotics is are the dopamine receptors with minor histamine. So sometimes we may have to give other things along with it if the patient is acutely agitated to sort of help with that psychoticism. But look here at the atypical. So now it blocks serotonin receptors, remember? The same thing as SSRIs. Actually, SSRIs are selective serotonin reuptake inhibitor medication, and it targets the 5-HT2 receptor. So here, the atypical ones also target serotonin, and that's why we use it for depression. That's why we use the atypicals like Seroquel, like Abilify, for Risperdal. There's all of them been used for bipolar. because it can also use the antidepressant effects of targeting the serotonin receptors. Here, it also has, let's see here, it also has some noradrenergic receptors too, depending on some of them. Other receptors, atypical antipsychotics also may interact with other receptors, histamine receptors, muscarinic receptor, alpha adrenergic receptors. Some of the different antipsychotics have different binding affinities for these different combination of receptors. And so it'd be interesting to look at the chart that shows all the medications and then all the receptors and things like that. You need to just take a look at that to see if it exists. I may show it one time. Okay, so now histamine, muscarinic, alpha adrenergic receptors. Okay, and then look, partial dopamine agonist. Yep, Abilify. Yeah. Look at these things. Yeah. I don't have too much experience with this one. My population is primarily a Medicaid population, so I don't get a chance to use as much of the newer medications. And the ones we use they're evidence based, so I don't think it's less care. I think I have more evidence behind what I'm doing. I'll wait till the newer ones have more evidence behind them before I start incorporating them into my treatment. So in essence, the broader and more complex receptor binding profiles of atypical antipsychotics is thought to contribute to their range of therapeutic effects and their generally better side effect profile than typical antipsychotics. Yeah. So mainly that's the difference between the two. And let me see if I have any questions here for now, okay? Let's see. Hey, Max, how's it going? Hey, Max, how's it going, buddy? Okay. Great. Hey, buddy. I'm really excited about this study, too. Okay. Are atypical antipsychotics truly safer, or they bring new risk? I think all of them are safe. I think all of them are safe. Considering the circumstances, patients come in with a psychosis, agitated, combative, aggressive. Of course, these medications are safe. I think they, they're safe. I think there's more concern over them than I've actually seen them do harm. Let me do this. Let me see if I can give a list of the typical antipsychotics. That'll be interesting. Say, give it from oldest to newest. See if we can get some structure here. Great. This is amazing. It's amazing. This is amazing. Right? Okay. So, Thorazine, 1954. So, I use this a lot. I really don't use this. I think this flufenazine is Prolixin here. I keep forgetting what this is. Okay. Use Haldol a lot. So here, I mainly use Haldol and these two. I don't, and then flufenazine is my backup. So I really don't use all the stuff here. I don't think we have it on formulary. So these are the typicals. Let me try this. Of the brand. Please list the brand name and generics names. For typical antipsychotics, I don't want to start paying stuff. Okay, great. This is great. Man, this is impressive. Okay, so here, so here are the three I use. Thorazine here. Okay, so Thorazine was the first, huh? Yeah. Okay, and then flufenazine, which is prolixin here. Okay, and then Haldol, which is here. I don't know anything about these. To be honest, don't know anything about these other medications. They may be used in other jurisdictions in other countries and things like that, not available. But yeah, here are the ones that I use. And so typically, if they were to come in very agitated, combative, aggressive, I would start off with Haldol, right? If Haldol didn't work, and if I needed something weaker than Haldol, then I would probably go with Prolixin, then something stronger, Haldol. And then if Haldol didn't work, then I go with Thorazine. And those are the basically three medications that I use. As you can see, when we round, in most occasions, I have to schedule Thorazine 3 times a day. And in many cases, we have to give them IMs to sort of help reduce the activity in that mesocortical pathway. But these are the names of the typical antipsychotics: Thorazine, Prolixin, the weakest, then Thorazine, then Prolixin, then Haldol, then Thorazine. All right. But if you had a text question, I'd probably go with Haldol. Prolixin is one of those older medications that we use as psychiatrists, but I'm not sure if it's going to store up on a text question. So Haldol will probably be the first, and then Thorazine the backup. So the next question is this. Let me see if I can read the brand of. Yeah. Okay, for atypical. Okay. What I thought Clozaril was. I forgot all about Clozaril as a typical antipsychotic. There's a difference between Clozaril, okay? But here, Clozaril is for when nothing else really works. If it's really treatment resistant, Clozaril is a very effective antipsychotic, but it's associated with agranulocytosis. And so you have to monitor it almost every week up until a certain point. Then you go from 2 weeks and you go from a month. And the patients on this medication are actually entered into a registry where the registry follows them and makes sure they've had the appropriate labs and things like that. Okay, so let's look at these. Risperdal, okay, Zyprexa, Seroquel, Geodon, Abilify, and Vega, Latuda. Okay, and so this is pretty much the combination of atypical antipsychotics we're used. And this is like your first combination of antipsychotics group of medications on the outpatient basis, right? So if someone's coming in with some symptoms of schizophrenia, some voices that's not agitated, then you want to go with the second generation, these atypical antipsychotics, right? And then if they're having mood symptoms to it, the atypicals are going to target serotonin, so they're going to have some antidepressant benefits associated with it. And I believe almost all of them also have the indication for bipolar disorder. So if you don't want to go to Depakote, if you don't want to go to lithium, everything, then you can look at an atypical antipsychotic as something to treat the bipolar or the mood disorder, things like that. And these work very well. Okay, let's see. So here, okay, hey, Max, what role will future medications play in balancing efficacies and side effects. It's going to be tough to develop newer medications that target dopamine because look how many we have. What about the medications that target glutamine? Uh, you know, um, um, so yeah, so I think that we're likely going to see innovations in areas outside of dopamine. Like in areas of glutamate. Let's say if with GABA, even if you can make medications for GABA that doesn't result in um, dependency, it'd be really interesting. Hello, Jazzy 2928. Umber, hey buddy, what's the best way to prevent tardive dyskinesia in patients who require long-term antipsychotic therapy? Lower dose and try to get them off the medications during periods of times where they don't have any symptoms, right? So if they have any periods of times where they're symptom free or the symptoms are not as intense, I always try to take them off the medications. And in fact, for these antipsychotics, it's very important, as you'll see when I round, is I always document if the patient is on one or more antipsychotics. And then also you want to make sure that you want to make an effort to reduce their dose of antipsychotic medications. So you want to, as their doctor, to make sure that you only have them on the minimum necessary. And if they don't need it, you take them off. And although there's surveillance and things like that um, helps that. Okay. Okay. Hey, buddy, how's it going? Atypical antipsychotics have increased metabolic risk, usually due to serotonin impact. I agree, buddy. I agree. And not all atypicals, but many. I agree, buddy. I agree. Um, okay, and I think that's it for today. I don't think I want to go any further. We're at 26 minutes, and I wanted these lectures to sort of like stay around 20 minutes. And sorry I went over. If you guys have any other questions, please let me know. You can put them in the comments, and I'll try to respond. But until then, choose your typical and versus atypical wisely, guys. And read out. Take care, guys. Ciao.